Video we are going to start about molar pregnancy. So first we should see what is gestational trophoblastic disease, because under gestational trophoblastic disease only this molar disease is present. Okay, so this gestational trophoblastic disease is first divided into molar pregnancy, and this molar pregnancy is in turn divided into a complete mole and a partial mole. And now coming to gestational trophoblastic neoplasia, and here we have invasive mole, which is the most common mole, and next most common mole comes the choriocarcinoma. So these are actually the neoplasia, means it's a cancer form, choriocarcinoma, and PSTT. PSTT means placental site trophoblastic tumor. Next coming to ETT means epithelioid trophoblastic tumor. Okay, so these are the different things which we need to classify. First, gestational trophoblastic diseases are divided into molar pregnancy and gestational trophoblastic neoplasia. Molar pregnancy is in turn divided into a complete mole and a partial mole. Gestational trophoblastic neoplasia is divided into four types. The first most common is invasive mole, next comes choriocarcinoma, next comes PSTT, that is placental site trophoblastic tumor, next comes ETT, that is epithelioid trophoblastic tumor. Now let us discuss in detail of molar pregnancy. Okay, so molar pregnancy is an abnormal proliferation of trophoblastic tissue filling up entire uterus. So here the problem is that the trophoblastic tissue has become mad, so it is filling entire uterus. Okay, so trophoblastic abnormal proliferation filling up uterus completely. Okay, so this is divided into two types. One is, there is, as this tissue is growing up entirely in the uterus, there is no space for inner cell mass to grow, so there is no fetal tissue. And this is called as complete mole. So what is complete mole is only this trophoblastic tissue is completely filling the uterus and there is no inner cell mass development. That is complete mole. And you have another type, that is, it is giving some space, only some space for inner cell mass. So some space for inner cell mass, only some part of fetus tissue is growing. So some fetal tissue is growing. So this is called as partial mole, because some of it is trophoblastic tissue, in middle some of it is our inner cell mass. So this is non-viable. Now coming to, in this case of molar pregnancy, you can see abnormal karyotype. Abnormal karyotype is seen in molar pregnancy. It is benign disease of trophoblastic disease with malignant potential. So this is a benign disease in the beginning, but it has malignant potential. So it may turn into dangerous if not treated immediately and properly. Okay, so this is about molar pregnancy, which you need to see classification. Now let us see abnormal proliferation of trophoblast. So abnormal proliferation of trophoblasts is divided into, according to size of uterus. If the size of uterus is greater than period of gestation, then on on PA you will see, on physical examination of abdomen, you will see there is dove-like abdomen. Because here you can see the size of abdomen is the size of uterus is larger than period of gestation. So you may expect any fetal tissue, but there is no fetal tissue. There is complete dove-like abdomen because there's only abnormal proliferation of trophoblast. Okay, next coming to abnormal pregnancy. This is of course an abnormal pregnancy, so this has to end because this is abnormal. So you see especially bleeding in first trimester in this kind of people, and you will have especially a special feature that is a grape like vesicles. So grape like vesicles are present in along with bleeding in the case of this molar pregnancy. And next, the patient will have PIH at early age. So you will get PIH at early age in these patients, that is less than 20 weeks. So just less than 20 weeks only there is pregnancy induced hypertension in this patient. And if you see the ultrasonography, it will show a snowstorm appearance. Okay, and if you see the beta Hcg values are very much increased. Why they are increased? Because there is now lot of syncytial trophoblasts. You know that trophoblasts will divide into cytotrophoblasts and syncytial trophoblast, right? And we know that the syncytial trophoblast forms a beta Hcg. So now as this cell is overly proliferating, of course even syncytial trophoblast will be more, and that will lead to increase in beta Hcg very abnormally. Okay, and even the hypertension is coming in the early age. So these are the signs which we need to see in this molar pregnancy. And so because of higher beta Hcg, what will be in this female is there will be hyperemesis gravidarum. If you remember, in hyperemesis gravidarum there will be more vomiting sensations, and alpha subunit of Hcg is similar to alpha subunit of TSH. We know this already, right? So this will lead to hyperthyroidism in these patients, and so there is increased chance of thyroid storm, especially during evacuation. So especially during evacuation of this type of molar pregnancy, you may have a chance of thyroid storm, because you know alpha subunit of beta Hcg is equal to alpha subunit of TSH. So there is higher risk of hyperthyroidism and increased chance of thyroid storm. And next coming to beta 1 theca luteal cyst. So you'll see beta 1 theca luteal cyst in ovaries, especially in this molar pregnancy. Next, there is increased chances of pulmonary embolism. So there are also chances of pulmonary embolism in this case, because you know, by deep vein thrombosis, maybe this some of the part of this trophoblastic tissue may pass through this and go into pulmonary artery and struck there. So now coming to risk factors, this is very important. So what are the risk factors? In risk factors you have vitamin A deficiency, and you have most common, it is seen in developing countries like Asia, and it is highest incidence, you see this disease in Philippines, and it is more common in AB type of blood group people. So whenever a patient comes with AB blood group, even though they may don't have this molar pregnancy, it's better to rule out whether they have it or not. Okay, so now let us start a discussion on partial mole versus complete mole. So till now we have discussed all the details, like all the basic details. Now let us go into its particular details of partial mole versus complete mole. So first, coming to karyotyping. In partial mole, normally if you see, partial mole is less common when compared with complete mole. Complete mole is most common in any case of molar pregnancy. And remember the complete mole, another names are like hyatidiform mole and vesicular mole. Okay, let me write it: hyatidiform or vesicular mole. Okay, these are the another names of complete mole, and this is most common. Coming to the karyotype, if you see in the partial mole, it is 69XXY. So why this is happening? Because there is only single ova, but the two sperms are coming. So you know, in the ova there is 23 eggs, In this sperm there is one of the sperm 23x, another one 23y. So because of this you can see x, x, y, 23 plus 23 plus 23, 69. So 69xxy is the karyotype, which is triploid actually. It's triploid in nature, and 5 to 10% of people may also have this type, that is 69xyy. So sometimes the sperms which will come here both may be YY, but this is seen only in 5 to 10%. In most of the people you will see this triploid condition, and this is a case of dispermic condition because two sperms are coming for the single ovum. So this is the karyotype in the partial mole. In the complete mole, the karyotype is 46xy, sorry, XX, 46xx. It's a diploid. Okay, here actually for the one ovum only one sperm comes, and this is empty ovum. Here the problem is this is an empty ovum, so only one sperm comes, and this is 23, right? This is 23, but it's a X. Okay, the genetic material doubles. So that's why it becomes, for this sperm only the genetic material doubles, so it becomes 46xx. In 5 to 10% people it would be 46xy, but only in 5 to 10% people that is dispermic. In this case, in this 5 to 10% people only it is dispermic, but in this normal case 46xx, here it is only monospermic, and this only is doubling to form this. Okay, but here it is dispermic because one X, one Y sperm may come and one empty ovum. Okay, so but this one is never seen, that is 46YY is never seen, that is 2 Y sperms and empty ovum is never seen. So if you remember this, complete mole will be mostly monospermic only. This is very important. It is mostly monospermic, but partial mole is mostly dispermic. So let us underline it, this very big one, because we should not confuse. Mostly complete mole is monospermic, partial mole is dispermic. Now coming to genetic material. The genetic material, here you have extra genetic there's extra genetic material which is coming from paternal origin, that is from the father, and there is maternal genetic material also present. Maternal and paternal both are present, but extra one is coming from the paternal, right? You can see here clearly maternal only one, but you can see dispermic, that's why extra paternal. Okay, and coming to this complete mole, here you will see entire genetic material is of paternal origin. Yes, of course, because mostly inside it's monospermic and it is only doubling, so it's paternal. Maternal genetic is absent here. Maternal genetic material is absent here. Now coming to immunostaining with P57. Actually we do immunostaining with P57. It is expected especially in maternal gene. So P57 will be present in maternal gene. Here there is also presence of maternal gene, so here it will be present P57, but here the P57 will be absent because here there is no maternal genetic material. Now coming to most common presentation that is bleeding in first trimester. So bleeding in first trimester is seen here, and there is no history of passage of grape-like structures, so no grapes here, like that you can remember. Whereas here there is bleeding in first trimester, and also there is a color. The color of the bleeding is here prune juice like appearance. This is important. It's something like prune juice, and there is also a history of grape like structures here in the complete mole. Now coming to height. If you see the height of uterus, it is less than period of gestation, and the height of uterus is equal to period of gestation. But coming to here the height of uterus is greater than period of gestation because it's a complete mole. Okay, and next coming to thecal luteal cyst. Thecal luteal cyst may be present or sometimes absent, but here the thecal luteal cyst is always present in complete mole. Coming to any complications, no complications are seen here, but here there is complications like hyperthyroidism, hyperemesis, gravidum, everything is hyper here. PIH because hypertension, right? And pulmonary embolism, so everything is high here in complete mole. Coming to ultrasound findings like TVS and IOC, here you will see there is missed abortion in USG. Okay, missed abortion, and here you will see a snowstorm appearance or honeycomb like appearance on ultrasonography. Okay, next coming to beta Hcg values, of course they will be high but not more than means you can say less than 10 power 5 international units, but here the beta Hcg levels will be very high, like 10 power 5 per liter, that is greater than 1 lakh. Here the beta Hcg is okay. And here the conversion to GTN, that is conversion to this gestational trophoblastic neoplasia, the chances are here 5% only, but here the chances are like about 20%. So here complete mole is everything hyper. So by this you can say like partial mole is somewhat better when compared with complete mole, right? And here the conversion to choriocarcinoma is less than 1%, but here the conversion even for choriocarcinoma is 4%. And now coming to management. So the management which you do here is just suction evacuation. Okay, even here you will do same suction evacuation, but here you will also do HPE, histopathological examination is followed here because it's a severe case. And what is histopathology? Histopathology is actually a gold standard. Histopathology is a gold standard where the fetal tissue is seen and chorionic villi are present. Okay, so let me write it down here. Histopathology is a gold standard for both the conditions. Okay, so in the case of partial mole, fetal tissue is present here. Okay, chorionic villi are present, vascularity is present, and hydronic degeneration. Hydronic degeneration is only localized here. Okay, and trophoblastic scalloping is present. Even inclusion bodies are present. So these all are present in the case of partial mole. But coming to complete mole, here the fetal tissue is absent because it's a complete mole, right? Here the chorionic villi are present, but they are avascular. Here they are vascular because some fetus is present, right? And here the hydronic degeneration is generalized. There it is localized. And here the trophoblastic scalloping is absent. There it is present, right? And inclusion bodies are absent here. There the inclusion bodies are present. Okay, so like this you need to differentiate. Just we need to actually revise this many times to get this, and by this you completed part 1. In part 2 we'll discuss management and everything.